Welcome to the Irish Occupational Therapy Podcast, hosted by me, Jen Trechek.
And me, Aileen Rutledge.
This podcast is dedicated to exploring the world of occupational therapy, sharing the latest research and techniques and providing insights into the many ways that occupational therapy can help people of all ages live more fulfilling and meaningful lives.
Whether you are a practicing occupational therapist, a student of occupational therapy, or simply curious about this fascinating field, this podcast is for you. We'll be interviewing experts in the field, sharing stories from the front lines of occupational therapy practice, and providing tips and advice for anyone looking to get the most out of their therapy.
So sit back, relax, and join us on this exciting journey into the world of occupational therapy in Ireland.
Today on the Irish Occupational Therapy podcast, we welcome Claire Murphy. Claire is the Occupational Therapy Manager for Cavan and Monaghan Hospital. Today we're going to find out about Claire's PhD, which she completed back in 2020, focusing on occupational therapy interventions to support the transition from institutional to independent living. You're very welcome, Claire.
Thank you, Aileen.
So Claire, to get started, can you tell us a little bit about your new role as the OT manager in Cavan General Hospital? How are you finding it so far?
Well, I'm still very new to my role as occupational therapy manager. It's only started back in October 2023. And my job is a half-time post. So even though I've actually been in post for technically 6 months, really I'm only there 3 months. So I do have to remind myself that I am only settling in, and then I have to adjust my expectations a little bit on a regular basis as well. I suppose I'm enjoying the change to management so far. I'd worked clinically for the last 15 years and always enjoyed working with patients and being a practicing occupational therapist. So it is a big change to management. And I would have particularly enjoyed my previous role within community mental health teams. But I suppose I would have resonated with Sarah English's podcast a little bit, where she talked about burnout. And I think maybe for me, it was a preventative action nearly, trying to get a better balance in my life rather than trying to work full-time, balance a busy home life with 3 young kids. And I suppose this role has offered a better work-life balance for me once I can maintain that 2.5 days working each week, which can be a challenge as well.
So Claire, the other 2.5 days you're at home with your kids, is that right? Or have you anything else on the side? I bet you have something else on the side.
I have a couple of things on the side, yeah. I'm doing, I suppose I'm in the early days of setting up some private kind of work as well on the side, maybe 1 day a week. But I do have 1.5 days where I'm definitely still going to be at home.
Tell us a little bit about the hospital, Cavan and Monaghan. What type of hospital are you working in, Claire?
So there are 2 separate sites. So Cavan General Hospital is the general hospital which would have the acute, medical and surgical wards. A lot of the surgical stuff would be, I suppose, traumas. There's not a huge amount of elective surgery that happens in Cavan, but sometimes then after having surgery in other hospitals, people are then transferred back to their local hospital in Cavan, and then that's where the major surgical ward would be. There also would be a FIT team, which is the frailty intervention team within the emergency department to try and prevent admissions. There's Listarn, which would be like a step down and re-enablement service. And then the second site is Monaghan Hospital, which provides rehabilitation service as well. So I would be responsible for managing both the occupational therapy services in both those sites.
And what type of interventions do the OTs that you manage provide, Claire? Because I suppose when we think about hospital OTs, we do tend to think about, well, I think about equipment provision.
I have the horrors. I started my rotation in a physical hospital, a really busy, big. It was the biggest OT department in Europe at the time, and I just remember stacks of equipment in this room and trying to untangle all of the different kind of chair raisers. Is that what you guys are doing? It's way more than that, isn't it?
It is. I suppose, as I mentioned, there's 2 different settings. So the interventions within the acute hospital in Cavan will be very different, obviously, than the rehabilitation hospital as well. So equipment provision can be a big part of the role. And I suppose it's mainly equipment which is essential for discharge. we work very much in partnership with the primary care occupational therapists as well. And I suppose there is some equipment that it isn't feasible or it isn't appropriate to provide without seeing the home environment. So oftentimes you're looking at the equipment that is essential for manual handling or essential for, I suppose, toileting or getting in and out of bed, things like that that are essential before the person goes home, and trying to have that organised. But like occupational therapists would carry out seating and pressure care assessments, trying to prevent and treat pressure ulcers, ensure optimal posture to promote occupational performance engagement. There's a lot of assessments of functional cognition as well to ensure that people are safe to go home, and to look at the impact of people's cognitive difficulties on their functioning as well. And I suppose that's always a piece of education that OTs have to provide, is around, there's no point in us doing just a cognitive assessment for the sake of it. As occupational therapists, we want to know what impact does that have on how the person manages to look after themselves and their home, etc. So there is some rehabilitation as well within the acute hospital, especially with patients who've experienced stroke, although there's not a specific stroke service at the minute in Cavan. And I suppose the staffing levels don't allow a significant amount of rehabilitation. So unfortunately, sometimes what the OTs are providing is more like a triage service, where you're assessing where the person is at the minute, assessing, is it safe for them to go home, or what supports need to be put in place so that they can manage safely, or else to try and support them to look at other services, for example, rehabilitation or step down, to allow them to reach an optimal level of functioning before they go home. As I mentioned, there's also, for example, a frailty intervention team. So we have one occupational therapist working in that multidisciplinary team within the emergency department, and her role is very much to identify older persons who are at risk due to frailty, and then to decrease admissions by providing a really timely intervention on their first presentation to hospital, or else to decrease the length of stay within the hospital by starting that multidisciplinary intervention at the earliest possible stage. And then some of the other occupational therapists who work in step down and rehabilitation or in re-enablement focus on facilitating those earlier discharges by providing rehabilitation, looking at assessments for home care packages, trying to get that all in place. And as you mentioned, organising the equipment for discharge. And also then another occupational therapist works in the early supported discharge service. So that's very much around providing rehabilitation within the person's home, to ensure that there's an earlier discharge as well. So it all comes under the umbrella of the acute hospital services, not just the equipment.
So the OTs are based in the hospital, but they might be doing some work out in the patient's home or in their community as well, potentially. It's not all just delivered on wards.
So there's one occupational therapist specifically working in the early supported discharge. So her office and the team office would be based within the hospital, but the majority of her role is out there in the community. For the other services, the majority of it happens within the home. And unfortunately, again, staffing doesn't allow that there's regular home visits. Well, I suppose there are regular, but it's not constantly home visits. Sometimes the home visits are carried out where it's essential, but often that other kind of community piece, you're linking in with the primary care OTs.
Mm-hmm.
Claire, you mentioned there, planning for people's discharge. So you obviously work very closely with social workers, do you? And other multidisciplinary team professionals? Yeah,
so like ourselves, like prior to me starting, the occupational therapy manager had been within primary care and managing primary care services and acute hospital service, and older persons, pediatrics, etc. So social work have only just recently had a manager, a principal social worker start within the service as well. So that's been quite helpful, having somebody else who's quite new to the service starting around the same time as well. But I suppose we're finding that with the introduction of the Assisted Decision Making Act, there are a lot of cases where there has to be that kind of shared collaboration along with social work, in particular around discharge planning as well. We'd also work very closely with the physiotherapists, and the occupational therapists and physiotherapists would share offices as well. So there's a lot of multidisciplinary working.
And what qualifications or experience did you have to help you to progress into management, Claire?
I suppose in order to progress into management, it's interesting that there's not specific qualifications required. You know, when you look at it, it's actually only 5 years post-qualification experience as an OT is generally required, which is not very much to go in and manage a service as well. I suppose, I know they're looking at different competencies, but I think having that kind of leadership and management experience is really important. I know my PhD would have provided me with a lot of experience in terms of developing services, managing resources, leadership and that. But one of the things that actually would have really helped me was being involved in the AOTI, and specifically with the conference committee. And that would have given me a very good opportunity to develop those leadership and management skills, getting experience around governance and accountability and that. Because I think often when you're working clinically, you know, as a senior occupational therapist, there's not that opportunity to develop those skills. So sometimes you have to look outside of your standard practice for that.
How many would be on your team, Claire, at the moment?
So technically, there should be 11 occupational therapy posts and 2 occupational therapy assistants when all the posts are filled. But I suppose, like all services, we've been very much impacted by the recruitment embargo within the HSE. There have been quite a few maternity leaves and also people who have left the service. So I suppose our service has, I think it would be 8 occupational therapists and 1 occupational therapy assistant at the minute.
Wow. So you're probably 3/4 of what you would need to be.
Yeah, and there has had to be. Yeah, it's very difficult, you know, when you're starting into a role and all of a sudden you're having to look at, okay, how do we continue to provide a good level of service to patients that's evidence-based, that is quality service? But I suppose there are some difficult things that you have to look at. And one of the things we've had to do, and actually it's more so because the re-enablement service, say, for example, is a multidisciplinary service, occupational therapy and physiotherapy. And similar to ourselves, physiotherapists are down a lot of staff. And one of their physios has had to go on maternity leave, can't be replaced. And it's impossible to provide a multidisciplinary service with only one discipline. So we've had to actually look at jointly with the physiotherapy manager, with the operations manager, bed management and everything, look at actually closing that service temporarily until staffing allows it. And then that has an impact then on the hospital. You know, you're seeing it on the ground of patients actually who would be able to be discharged earlier from the hospital to the re-enablement service. They have to go somewhere else, or else continue to occupy hospital beds, which, you know, is unnecessary if the service is available. So that's quite a challenge. And, you know, you're very much reliant on the goodwill of staff as well around moving around. And in fairness, the OTs are fantastic who I'm working with and have been so obliging, are willing to move around as needed as well, so that the patients continue to get the best possible service.
It's a huge challenge when we think about the move through from A&E, and you know, there's a lot of call obviously for support and immediate support, acute support. But I guess unless there's the OTs and the multidisciplinary team in hospitals to move people through, there's a funnel, isn't there? People will get stuck. So
Yeah.
we really do need to advocate for more support to move people through the hospitals.
And the other thing is that occupational therapists are the discipline that have been shown to actually reduce admissions and then reduce costs to the service. So it's interesting, you see that now the HSE, that there is some move in the recruitment embargo, but not HSCPs. And generally the HSCPs are the people who keep people out of hospital or prevent them from going in the first instance, and also get them out earlier. So it seems quite narrow-minded to stop recruitment of occupational therapists, physiotherapists, and all your other HSCPs who are so important in that role as well.
Preventative piece is huge. Yeah, makes sense.
There, that is quite a team actually. That's quite a number of OTs and OT assistants that you're managing, and obviously then you have your budget to manage. What is the most kind of stressful or challenging aspect of your role so far? Is it overseeing all of that so that it works as smoothly as possible, or are there any other challenges that really you're faced with?
I think, like you say, making sure that it all runs smoothly is a challenge. And I suppose you are just a very low layer in management as well. So I suppose your level of decision making and responsibility, it impacts a small number of staff, and ultimately all the decisions are made over you. So sometimes you kind of have to remember that actually it's okay for me not to be able to do this. You know, I have to identify the risk in this area and actually pass it on, and being able to sit with that risk as well. I think the recruitment embargo has definitely been a major challenge, and coming in October, and then the recruitment embargo starting in December, you know, that's been quite a challenge as well. But even before that, you know, there's always tightening of budgets in the HSE, and there would have been, you know, maternity leaves that weren't being replaced even when I started because of tightening around budgets and everything coming to the end of the year. So that's a difficulty because, you know, staff want to provide a really good level of care. The service, you know, you want to develop things, but where there isn't the people there to do that, that can be a huge challenge. The other thing is you're seeing the impact on short staffing on the staff who are working on the service. And that can be challenging as well, that you want to try and manage stress for other people and trying to make sure that the systems and processes are in place. But I suppose it links back to the other challenge for me, which is time. So I'm only working 2.5 days, and the priority tends to be things like making sure that people get paid. So making sure that returns are in, making sure that the people's leave is accounted for, making sure that services are covered, all the basic stuff that have to be done on a weekly basis. So then the things that, you know, you've all these ideas for service development where you want to develop things and improve things, and it ends up going, okay, I'll do that next week. So you put in the diary for next week, and often you don't get to the things that you really, really want to do, and the things that'll make a huge difference as well. So that can be a major challenge as well.
And it's similar to private OT. It's kind of working in the business rather than on the business. The whole developmental piece is huge and hugely important, but hard. It often falls to the bottom of the pile, doesn't it?
Yeah, and I think I would have done the first time managers program quite recently, and I know they talked about, you know, those kind of priorities, and often you get caught up in the things that are immediate priorities, and you don't actually get to work on the things that actually they're not the immediate priorities, but they try and sort out the short-term issues. So rather than just firefighting, you can solve some of the problems that lead you to needing to firefight all the time.
You mentioned the changes in legislation as well, and the introduction of the new
Assisted Decision-Making Act.
Yeah, absolutely. All of those must mean lots more training continuously as well for the team in terms of staying up to date on and making sure that what you're offering is safe and in line with the legislation.
Yeah, and it's quite difficult because it's so new. The legislation is still being tested. You know, there are different cases going through the court. So people are very much learning as they go along and trying to figure it out together. I suppose myself and the social work manager have talked about trying to set up maybe some kind of monthly learning forum. So like there are grand rounds, say, for example, that happen on a weekly basis in the hospital. So, you know, we're going to look into the possibility of having either on a monthly basis or every 2 months of having a kind of a learning session where cases are presented, more complex cases by more than one discipline. And it gives people an opportunity to learn from what happened, what went well, you know, what would be better to try in the future if a similar case come up as well.
That sounds like a great initiative. And I think it's really helpful, and I think it's important for the general public to maybe be aware of some of the pressures and challenges, you know, in acute services, because I think we see the waiting lists and we see our family members not getting in or not getting support or not getting out quick enough, and the frustration that can cause, understandably, for relatives and friends is there. But on the other side of it, there's a whole host of professionals who are desperately wanting to do a really good job without necessarily having the resources or the capacity to allow them to provide the kind of service that they want to be able to offer.
Absolutely. And another thing, I suppose, with the Assisted Decision-Making Act, you know, for family and friends, they're seeing somebody who they feel cannot manage at home. And, you know, as a team, we're carrying out the assessments, and the patient themselves, you know, is saying, I want to go home. And they have the ability to make that decision themselves. you know, for family and friends, it's very difficult to understand that this person is being allowed home, because that is the legislation and it is the person's right to decide where they can go. And I suppose that kind of positive risk taking is quite a change to what happened in the past. So I suppose that can it can reflect quite badly sometimes, or it can reflect quite negatively on the service then, that, you know, you're letting our family member go home and they're not able to manage.
That must be really
Yeah.
stressful and conflicting, actually, as the OT involved in that.
Yeah, I think so. And you can see it in staff, you can see it on a regular basis where, you know, they're kind of saying, you know, how can we let this person go home? You know, this is going to fail, you know, something negative is going to happen. But staff are having to sit with that risk around, you know, this is the person's, they have the ability to make that decision, and things are allowed to go negative because they understand the consequences too. I was trying to put the supports in place to try and support them to be more successful when they do go home.
Claire, you mentioned there about the learning, the monthly learning opportunities. That's something new, obviously, that you're bringing in your new role. Are there any other aspects of your new role that really excite and motivate you? Share any of your plans or your dreams with us.
A lot of the stuff is depending on resources. So there are always areas for development. And I know the occupational therapy manager looking after the service prior to me would have started a lot of work around looking for stroke-specific occupational therapy services, looking at oncology. So there are huge opportunities there for developing the occupational therapist role within the hospital. You know, I've also linked in with the renal services, looking at developing a specific role there. But I suppose right now it's quite difficult to proceed with a lot of those development posts because the funding is not there. I think one of the things I'm enjoying doing is the supervision of staff and looking at trying to support people in their continuous professional development, and looking at opportunities for it, and trying to get people to think about prioritizing time for them to develop their skills and their expertise. One of the things I would have set up in my previous role was a virtual journal club. And I'm planning to set that up in the coming weeks as well within the service. And I think that's a nice way of trying to stay up to date with some of the literature that you've been putting in a pile that you want to read, but you never get a time to do it. But actually you're discussing it with your colleagues and you're talking about, okay, where's the learning for our service here? What small steps can we take here? So no, that would have worked well for us in the past.
That focus on evidence-based practice is really important for you. And I know that you have, you know, a passion around kind of understanding the evidence base for our clinical interventions, and you ended up doing a doctorate in occupational therapy, which is some mean feat. Fair play, congratulations.
Thank you.
In terms of your research that you've done to date, or your doctorate, or how you're kind of bringing research in, is there anything that you'd like to share in relation to that?
Well, I suppose the PhD, I hadn't initially intended to do a PhD. I'd always planned to do a master's. Even when I was in college, you would have always planned to do it. But I struggled to find a topic that I wanted to do a master's on. And I kind of realized then after a while that actually it was a research master's that I wanted to do. I wanted to do something very focused on my own clinical work. So I started doing a master's philosophy, or an MPhil, through Galway University. And I had a mentor at the time in Dr. Mark Morgan Brown, who has now retired, who I shared an office with. And he would have always encouraged me to think about doing the PhD. But initially I would have said, no, I'm just doing a master's. But it was when I would have gone to some of the kind of shared learning events with master's students and PhD students. And I suppose it was probably about a year into my course at that stage, maybe less. I remember sitting there looking at other people's projects who were doing PhDs, and I thought, oh, okay, there's nothing that is necessarily groundbreaking about the PhD. You know, a lot of that sounds like it's very realistic, it's very achievable, and actually there's not a huge amount more work in what I am doing to get to that stage. So I started then thinking about, okay, could I build on the project that I've started as my master's to move to a PhD. So I think maybe after I was doing a part-time, so I think maybe about 3 years after doing a part-time, I transferred over then to the PhD by adding on an extra layer to the PhD or to the project that I was doing already. So I was looking at the transition from a mental health institution to independent living, and using case studies where an occupational therapy assistant would have worked intensively with 2 young men with schizophrenia who are moving from a 24-hour supported hostel to their own home in the community. So prior to that, the support would have been available, say, Monday to Friday, 9 to 5. You would have had OT maybe once a week, nursing support, where these 2 young men were doing courses. They weren't there Monday to Friday, 9 to 5. And actually what they wanted more support was to integrate in their local community, to join clubs, to meet friends, to learn to manage their own home as well. So the occupational therapy assistant role was under the supervision of the OT to support the young men with their own goals. So things like joining the football club, putting out the bins, managing to clean their house, making friends, getting jobs. So the initial project was looking at the change in occupational engagement, quality of life, functioning in general when people were doing their own doing their day-to-day tasks. Where then the PhD, the extra kind of piece on it mainly was around a cost evaluation of the difference in the kind of approach of looking after somebody in an institution versus managing your own home with that support within the community.
Wow.
So it definitely ties in very well to your new role, Claire, as
It
well.
sounds like there's huge parallels, isn't there? It's so funny because when we think about OT and people look at an acute hospital and they look at a mental health community and might think they're completely different. But essentially what you're saying here is actually it's about OTs can save money, the preventative and then the support into the community to stop people getting stuck in that acute care or that intensive support. It's the same principles, it's just a different underlying reason.
Yeah, and I think it can be quite unusual to move from mental health to acute, because often people don't see the similarities between it. But I think when you're looking at occupational therapy and looking at occupational engagement, you're looking at what's important to the person, what goals do they want to achieve, and what interventions can we provide to support them to transition as well. So I think like one of the big things for me is the cost, as you say, as well. Like we don't look at how our interventions can save money, as well as supporting people to achieve their goals and have a better quality of life. So there are things I ideally want to do within my current role. But I suppose, like I said, it's getting the time to do all these great ideas that we have.
Claire, you talked about your young family at the time that you were embarking on your PhD. You were a mum. I'm presuming you were still in full-time employment. How did you balance it all? How long did the PhD take, and what was your approach to it all?
Well, just to clarify, when I started the PhD, I had no children.
Okay.
So that made things a lot easier. I suppose I did it part-time, which can be a huge challenge, thinking of juggling full-time work and doing a PhD part-time. So it was evenings, it was weekends when I was doing a lot of the work. But because it very much was part of my clinical work as well, so I was working clinically with these 2 individuals who were the participants in the PhD. So a lot of the data collection happened during work. The occupational therapy assistants, I was supervising them during my clinical work as well. So there was a huge overlap between the clinical work and the PhD. So that certainly helped things. And I think it would be very difficult doing a PhD where you're working full-time, doing the PhD part-time, and has absolutely no overlap with your clinical work. So at least some of the work got done during my work days. But I think I would have very much learned a lot around prioritizing, and like some of my skills for PhD, like at the very end of a day when I had done some work in it, I very much made a list and said, okay, next step is 1, 2, 3, 4, 5. So as soon as I came back to the PhD, maybe after a couple of days, I knew exactly where to start off again. I find that so important, and I think it's something that I very much carried over to my own work life as well, around prioritizing the things I want to do, making a plan, so that especially working part-time, when you've had a few days off, you're trying to figure, okay, what do we need to do? Where do we need to catch up? So that certainly helped. Other things with the PhD, I think choosing a topic that is really, really important to you, and something that you're not going to get fed up of after a number of years. So obviously it can take quite a long time to do a PhD part-time. I was having maternity leaves in the middle of them, so it extended, and that gave me a bit of a break, believe it or not, because I had time off. But I suppose for me, it was trying to get it done as quickly as possible.
How many years in total was it from your
I technically started it in 2014 and handed in 2020. But there would have been, I suppose, some gaps with maternity leaves, during it. So I think it was 4 years that I did it over, 4 or 5 years. I can't remember the exact number. I tried to forget, to be honest, at this stage.
It's nice to hear about a PhD research project that's very much grounded in your day-to-day clinical experience. Because I think when I sometimes think about PhDs, I do think about very research heavy, academic. I know it's academic, but going down the academic route, theoretical, rather than really grounded in the reality of the work that we do day to day anyway. So that's a really nice kind of insight into that being possible.
I think because I self-funded as well, so I was coming with the topic, and I was coming with my own agenda. I think it made me much more self-directed as well. And there are huge benefits in doing a PhD where it is part of a program. You have a supervisor, and it's very much involved in a larger project sometimes, or the approach of a school, for example. And you see a lot of the researchers who are doing a PhD, and it's linked to a specific topic, where they're coming in and they're maybe taking on a topic that's been put down there as a PhD, and they get a huge amount of opportunities for networking with other researchers. They're doing it full time, they're getting funded, they're learning lots of other skills, but they can be very theoretical, a huge theoretical focus on them. They're very much directed by other people, where that was one of the joys of my own piece of research, is that yes, I do like the academia and stuff in ways, but the clinical practice comes first for me, and then the theory on top of it.
With us, the financial implications of completing a PhD, how much on average did it cost?
My understanding is there was approximately 2,500 each year with the University of Galway. I think that's a bit cheaper than some of the other colleges, because I understand that the PhDs in Galway, University of Galway, are aligned with the School of Science. So I suppose it would have cost about 10,000 basically to complete the PhD then over the space of 4 years. But you can claim back your fees through revenue. So I would have got a considerable amount of that feedback. So I wouldn't have actually ended up having to pay the full, well, I had to pay the 10,000, but I got my fees back each year, which made it a little bit more manageable as well.
So it's definitely an investment and a commitment, but there's a return on it. And it sounds like maybe shop around if you're looking for the right college.
Yeah. And I think a lot of people, it's about investing in yourself as well. A lot of people will do a master's and self-fund a master's. I know that can have a considerable financial implication as well. But I suppose, unfortunately, we don't get additional income as occupational therapists for completing masters or PhDs as well. But at the time when I started doing the PhD, I was actually still in a basic grade role. I had been for over 10 years, and it was a time where I wanted to stay in the one area. I wasn't looking to move. And I was having to wait for a senior post to come up. And I wanted to be able to stand out a little bit, in interviews. Was one of my motivations as well. And when you're feeling a little stuck, you have to look at other avenues to try and develop skills. So I suppose that was part of my motivation for doing it as well.
And you then you very generously gave your time to the AOTI to run the AOTI Occupational Therapy Conference for the past few years. So obviously research is really important. Is there anything that you would advise potential researchers or people who are thinking about a PhD from an occupational therapy perspective? Anything that you would recommend or suggest to them?
I think it's finding your reason for doing it, looking at why it's so important to you to do it. Because if you're doing something for anything from 4 to 6 years, you need to be motivated to do it. And then to look at the different options of doing, whether it's something that you're really passionate about, and you have a particular passion project that you want to research, and whether you're passionate enough about it to self-fund doing it, or whether there is something out there that will match your interests as well. And maybe there's a program, PhD there, which you would like to do. Because I was quite naive going into doing my PhD, one of the things that I hadn't thought about was having a co-supervisor. So I had one supervisor, and I see some of the other people who've done, I say like Anya O'D, for example, I know she would have had several supervisors, and that we've talked about the benefits of having more than one. I think looking back, it would be to have different perspectives in that. I know I had a mentor in Mark that I would have worked with, and he would have given me a lot of kind of informal advice as well. But I think it's really, really helpful to have more than one person who is interested in your project, who is backing you as well. Another thing is, if the research is fairly new to you, the MPhil is a nice way to go into it, where you're looking at doing a smaller piece of research first and then building on it. But the other thing is just to start off doing a small piece of research in your own clinical practice, and see if it's something that you enjoy, if it's something that you're willing to stick at as well, and if it's something then that you can actually build on. Like for me, the project that I was doing was going to be researched anyway, so it kind of made sense. I was thinking about doing a master's, right? Okay, I might as well do a master's on top of this because I'm doing the work anyway, and then I get all that support from the college as well for it.
Yeah, Claire, you've shared that in the past, where you've said, if there are OTs that are interested in researching or looking into a particular area of practice in more detail, they should reach out to the universities and collaborate with people who are looking for new projects.
Yeah, absolutely. Yeah, I think it's so important that actually we try and do research in a silo, and you're only one person often, or a small team, and you're trying to figure it out as you go along. And often the universities then, they're actually looking for projects. They don't necessarily have the same access to patients, but they have a huge amount of expertise there around doing research, and can help you plan and develop and run your research project. So, it can be so important just to collaborate there as well.
Yeah, Claire, that's been really helpful on lots of fronts. First of all, on the management front, I'm sure there's occupational therapists who would like to pursue a career in management and progress into management, and also people who are maybe considering doing a PhD or some level of research within their clinical practice. So thank you so much for sharing all your wisdom with us this morning. And you've been a very welcome guest on the Irish Occupational Therapy podcast.
Thank you. Thanks for having me.
That's all for today's episode on the Irish Occupational Therapy podcast. We hope you enjoyed our discussion and found it informative and engaging. If you've any questions or comments, we would love to hear from you. You can email us at irishotpodcast@gmail.com or connect on Instagram or Facebook.
And remember to subscribe to our podcast so that you never miss an episode. If you found this episode helpful, please leave us a review on your preferred podcast platform. Your feedback is important and helps us to improve the show, so please do leave it. Thank you for listening to the Irish Occupational Therapy podcast, hosted by myself, Jen Trechak.
And myself, Aileen Rutledge.
We look forward to sharing more insights and knowledge with you in future episodes. Until then, take care.